This is Christina Russo and Anahita Sadat, and our systematic review deals with the use of the Swash orthosis, which is the sitting, walking, and standing hip orthosis, and botulinum type A toxin used in children with cerebral palsy. The purpose of our systematic review is to appraise the literature on the use of the Swash orthosis, the Swash orthosis and botulinum toxin type A on gross motor function and the prevention of hip displacement in children with cerebral palsy. The research question that our review is based off of came from a currently practicing pediatric physical therapist, and she expressed interest in the effectiveness of the Swash orthosis in the prevention of hip displacement, as she has seen an increase in the prescription of this device in her own clinical practice. We wanted to provide you with an overview on cerebral palsy so we can better address the importance of our research. Cerebral palsy is the most common of all childhood motor disabilities, and this is an umbrella term used to describe a non-progressive neurological disorder caused by a brain injury or brain malformation occurring while a child's brain is still developing. CP affects fine motor skills, gross motor skills, posture and balance, and the clinical presentation is going to vary between each individual due to the variations in the location of their brain injury. The second most common impairment seen in children with CP is spastic hip displacement, and this is progressive lateral displacement of the femoral head from under the acetabulum. Hip displacement is caused by delayed motor development accompanied by spasticity and lack of weight bearing that's necessary for normal hip development. This is the problem because hip displacement can lead to hip dislocation, and that requires surgical intervention. So to manage hip displacement, hip surveillance is used to monitor the hip development over time and to determine the need for necessary early interventions. Hip surveillance includes identifying the child's gross motor function classification system level, or their GMFCS level, and taking radiographs of the pelvis and hip joint. From the hip radiographs, a hip migration percentage, or the amount of lateral displacement, can be calculated to determine the extent of the displacement. And hip displacement can cause the child pain, decreased quality of life, and functional limitations, which we know are important aspects for us in patient care in the physical therapy practice. I mentioned that identifying a child's GMFCS level was part of hip surveillance, and this is because the risk of progression from displacement to dislocation is directly related to a child's gross motor function. The GMFCS is a 5-level classification system, and it was provided to you in your handouts tonight. So the more functionally limited a child is based on their GMFCS level, the greater the risk that child has of hip displacement. Botox is a protein and neurotoxin produced by the bacterium Clostridium botulinum, and it is used to block nerve activity in order to reduce muscle activity. Spasticity and/or muscular imbalances, particularly in the hip flexors and adductors, can cause abnormal hip development in children with CP, so intramuscular injections of Botox have been used to reduce that adductor spasticity in order to improve passive range of hip abduction. This is the Swash orthosis, which I mentioned before, and it is a variable hip abduction brace that allows hip stabilization, but also allows the wearer to participate in functional activities. The orthosis, as you see, consists of a pelvic component with 2 thigh cuffs, and the wearer's hips are maintained in abduction, and this degree can be adjusted. So for example, when the hips are extended, hip abduction is going to be a lesser degree to allow the child to stand and step without scissoring, and then in sitting, with the hips flexed, the brace allows a greater degree of abduction. Moving on to our methods, we use the listed search engines and search terms to conduct our review. And our inclusion criteria, which qualified a study to be part of our review, consisted of peer-reviewed randomized controlled trials with study participants including children 2 to 18 years old with cerebral palsy and adductor spasticity. Articles were excluded if the participants had previous hip surgeries or their CP diagnosis focused on upper extremity involvement. This is our PRISMA, or our search process, which allowed us to arrive at 3 articles that met our inclusion criteria. And then 2 reviewers independently scored the quality of our 3 randomized controlled trials that met our criteria using the Pedro scale, which again was given to you tonight. Our mean Pedro score was 6.67, and common items of deduction included blinding of all subjects, blinding of all administering therapists, and blinding of all assessors who measured at least one key outcome. Factors considered throughout our review included gross motor function, prevention of hip displacement, and progression of surgery over the long term. And now Christina will continue with the results of our review.
So our systematic review was unique in the fact that it consisted of 3 sequential RCTs. The first was a baseline measurement and initial follow-up at 1 year. The second was an intermediate follow-up at 3 years, and the third was a long-term follow-up at 10 years. All 3 RCTs consisted of the intervention group of Swash orthosis and Botox injections, and the control group, which was whatever that participant's physical therapy management was. It is important to note that the intervention group received the Botox injections every 6 months and wore the Swash orthosis during the initial and intermediate follow-ups only. The third, the long-term follow-up, was strictly a long-term follow-up. All 3 studies also used the same assessments for hip surveillance, which included the standardized GM-FCS that Karen had mentioned before, and hip migration percentage. Measurements between 10 and 40% qualified subjects as having hips at risk. The first study included 39 participants who were measured at baseline and followed for 1 year. They received an additional gross motor function evaluation using the GMFM, both total and goal scores, and the GMFM 66 score. These standardized assessment tools are explained in more detail in the handout which you have received. The 39 participants were assessed every 6 months, and both the intervention and control groups demonstrated an improvement in gross motor function. However, when compared, between group comparisons were insignificant in all 3 outcome measures. There was moderate correlation between the change in GMFM total score and GMFCS level. Participants in GMFCS levels 2 and 3 achieved a greater improvement in gross motor function in the intervention group. This showed that the milder the impairment, the greater the improvement. At the 1 year follow-up, a total of 9 participants required surgery, and 2 were from the intervention group. So the first study included, the initial 39 participants were then included in the second study. This study had a total of 91 participants who were followed for 3 years. All 91 participants were assessed every 6 months for 3 years. Annual mean hip migration percentage difference and GMFCS analysis difference were reported in unweighted and weighted terms. And as you can see on this slide, both results showed no significant differences in the annual rate of change between groups. At the 3 year follow-up, a total of 33 participants required surgery and 11 were from the intervention. The third study then included 46 of the 91 participants from the previous 2. These participants were followed for 10 years. So there was no significant difference in mean hip migration percentage between groups in the long term. Hip surgery, whether preventative, reconstructive, or both, was needed in 40 out of the final 46 participants. This table outlines how many surgeries of each type and in which group were needed. These numbers add up to more than 40 due to the fact that some of those 40 participants required more than 1 surgery. However, this was not outlined in our research. This timeline illustrates the results in terms of the number of participants that progressed to surgery, which Anahita will now take you through in our conclusion.
After assessing the 3 studies, we learned that the researchers failed to use entirely consistent outcome measures. As indicated by the convergence in this diagram, the GMFCS levels, the timeline reports, and the number of participants who progressed to surgery were the only consistently reported outcome measures. Over the 1 and 3 year follow-ups, when compared to the control group, the intervention group had a smaller change in hip displacement and a prolonged time in which the children in GMFCS levels 2 and 3 specifically were progressed to surgery. Over the long term, at the 10 year follow-up, there were no statistically significant differences between the intervention group and the control groups in their ultimate need for surgery or in their hip development. The chart here demonstrates the percentages of participants who at the follow-ups reportedly progressed to either preventative or reconstructive surgeries. The green represents the intervention group and the blue represents the control. By 10 years, there is a scarce difference between the intervention and control groups for their percentages of participants who had to progress to surgery. This demonstrates a lack of support for the long term for the effectiveness of the Swash and Botox combined to prevent hip displacement. In terms of clinical relevance, the intervention used in the systematic review lacks evidence over the long term to improve gross motor function, to reduce the need for surgery due to hip dislocation or as a precaution for those hips at risk, or to enhance their hip development. When treating children with CP, PT should remember that spasticity is only one factor that may lead to progressive hip displacement. Structural deformities such as femoral anteversion or valgus may predispose the patients, which may also be a possible reason that by 10 years, the intervention group only had a prolonged progression to surgery versus actual prevention of the surgery. However, many parents may want to avoid the surgery and might look for a therapy program first. So it's important for PTs to remain mindful, because if they can just use a non-operative procedure, they can decrease that need for surgery and ultimately decrease the time needed for recovery as well. Further research to examine the efficacy of the Swash orthosis in conjunction with Botox to prevent hip displacement would include larger cohorts with more diverse sample selections to just improve the generalizability, more consistent participation involvement, and then standardized reported outcomes just to improve the consistency of the overall results. And finally, varying the duration for which the participants must consistently wear the orthosis, because for these particular series of interventions, it only called for 6 to 8 hours of wearing per day. We would like to thank our faculty advisors, instructors, families, friends, future colleagues, and all of you here tonight. Thank you for listening. Do we have any questions?
Okay, questions?